She's got polycystic kidney disease and has been followed in the chronic kidney disease clinic for quite some time. She also has a long-standing history of eczema, has had her tonsils or appendix out, and also gets some asthma once in a while when she exercises. Medication list is pretty unexciting. She's not started on any erythropoietin yet. She's on the Replovite vitamin, hydrocortisone cream for eczema. Social and family history is unexciting. She comes to chronic kidney disease clinic, and ignore the fact it's a male arm. Just the point of this is that she has a fistula in place. And you can see by her blood work, her creatinine is 876, her urea is really climbing, it's at 42, and she's starting to develop some hyperkalemia and some metabolic acidosis. And so she's also got some uremic symptoms, she's quite fatigued, she's got nausea in the morning. And so the decision in the chronic kidney disease clinic is made that she really needs to start dialysis. It turns out her fistula is ready to use, and so she goes to the dialysis unit and starts her first treatment. And 14 minutes into her first treatment, she complains of acute onset of shortness of breath. She also at the same time says, you know, it's funny, even though I have shortness of breath, I also have some cramping. Just my belly's really, really sore. You notify the on-call nephrologist who asks, you know, over the phone, please stop the dialysis treatment until I can come and take a look at the patient. The nurse stops the dialysis treatment, returns the patient's blood, provides supplemental oxygen. Okay? So, first question. What do you think, based on purely this and nothing else, there's no further information available to you, what do you think the most likely cause of Mindy's symptoms are? So she's got acute onset, shortness of breath, 14 minutes into dialysis, with some mild abdominal cramping, nothing else. Her vital signs are still relatively stable. So what is the likely cause? So each of you have a piece of paper, each of you have a pen. I'd like you to write down, this is question 1, what's the most likely cause? I'll give you guys a minute to write it down, what you guys think is happening here. Sure. And it's acceptable if you write down more than one answer, because there's not enough information to know definitively what the answer is here.
Questions for you, but
So just write down what you think is the most likely from those, and what are some other possible ones.
Is anyone mad if I close this? I can't really.
So I'm giving you another 30 seconds.
Oh.
All right. So Mindy is sent home, okay? From the dialysis unit, she's sent home. She's been stable. The shortness of breath stopped. She's sent home. She said, you know what? You need to come back to dialysis tomorrow. She comes back the following day. 9 minutes into the second run of dialysis, she develops dyspnea, swollen tongue. She's got hives that she feels itchy all over her body. She's itchy all over. And in fact, her blood pressure has fallen to 69 on 43. Okay? The dialysis nurse again contacts the on-call nephrologist who says, you need to stop dialysis, please. Dialysis nurse stops the dialysis, returns the patient's blood, supplies supplemental oxygen. Okay? So, same question. What's the most likely cause in this situation of Mindy's symptoms? This is question 2. I'll give you a minute. These are delicious cookies. They're very good. Do you have a minute? You good? Okay, I'm going to go on to case 2. Okay? So case 2. This is Sunil. Sunil's a 58-year-old gentleman from Sri Lanka. He has end-stage kidney disease from diabetes. He's got some significant complications from his diabetes. In addition to the nephropathy, he also has neuropathy. He's had his gallbladder and his tonsils out, he's got high blood pressure, he's got high cholesterol, he's had a coronary artery bypass grafting in Sri Lanka in 2012, and he's also had a little bit of hypothyroidism. His medication list, pretty simple list. He's on Eprex and folic acid 3 times a week with dialysis, and the rest are related to his coronary artery disease medications. He's visiting Kingston from Sri Lanka, and he's dialyzing in the renal unit. He's now there for the 4th time, okay? So he's been there for about a week. He's now starting the 2nd week in dialysis with you, okay? And 30 minutes into treatment, okay, he develops sharp chest and back pain. He's unable to communicate his discomfort because he doesn't speak any English. Dr. Willie Hinda is paged, is able to communicate with the gentleman, and so comes to the clinic, comes to the dialysis unit, is able to communicate. During that whole time, dialysis has been continued. And interestingly, by the time Dr. Willie Hinda has finished talking with the guy, the chest and the back pain's gone. Okay, it's pretty much gone. So, what do you think the most likely cause of this gentleman's symptoms are? Again, I'll leave the same list up here. So this is question 3. I'll give you a minute. Okay, I think a minute's up. So I'm going to go back. So, case 1. Who thinks this is an air embolus? Who thinks it's a myocardial infarction? Number 3? Number 4?
Maybe number 4.
Number 4? So number 4 is dialysis-associated hypotension. Okay. What about dialysis disequilibrium? Dialyzer reaction? So we have one for, so only one person answered.
Number 6.
Okay. Okay. What about this one? The second one. High urticaria, dyspnea, swollen tongue.
Number 6.
Okay. Does anyone think this is number 1? Number 2? Number 3? 4? 5? 6? Okay, 3 hands.
Yes.
A lot of non-voters here.
6.
Okay.
6.
Okay. And this guy here, what do you think his reaction is? Air embolus, MI, number 3, number 4, so maybe urea pericarditis, maybe. Number 5, number 6, number 7,
What is number 7?
dialysis-induced hypoxemia.
Okay.
So we have one person voting. We have one vote in a room of like 10 of us? Okay. Okay.
I was going for actually for number 7.
Dialysis-induced hypoxemia. Okay. Okay. All right. Well, let's go through it. So, this being a talk on dialyzer reactions, I'm going to move now to talk about dialyzer reactions. Okay. So there's a number of types of dialyzer reactions. 2. So the title of today's talk was A plus B, but not C. Right. So there's actually 2, and they're called A and B. A, you remember nothing from today other than type A, serious, potentially deadly, type B, not serious, and probably nothing's going to happen serious to the patient. Okay, so the most important thing, A, serious, A, anaphylactoid, B, not serious. So A tends to happen fairly quickly. So you won't get an A type of reaction in the last hour of dialysis. Okay, dialyzer reactions happen literally within the first 20 minutes if it's type A, or within about 20 to 40 minutes, a little later if it's type B. The classic presentation from a symptom perspective is in type A, anything that you associate with allergy, so shortness of breath, swelling, burning and itchiness, hives, the impending sense of doom that you have with an anaphylactic reaction, they'll sometimes complain about it. They'll say, something is really wrong. I don't know what's wrong, I just feel not right. I just feel something is not right. Then there's a spectrum. As it gets worse, they'll actually get hypotensive, and some of them will actually pass away. It is something that can kill someone. Okay, it's a very, very concerning. Type B, they really only get chest and back pain. That's it. That's really the most common thing. They don't get much else. And it tends to be much later. So the problem is if you get chest and back pain at 20 minutes, you say, well, that could be a type A or a type B reaction. And you're right, it could be. There is some overlap. As you see, I don't know why this moves ahead on its own without me doing anything. So the type B is actually relatively common. Okay? About 2 to 4% of patients will have type B dialyzer reactions. So it is not at all uncommon. It is mild, whereas type A is much more severe and much more uncommon. The risk factors are very long, okay, but we thankfully have eliminated some of these risk factors in our patients. Honestly, don't know why this is just moving on its own. Okay, well, let it move on its own. So the risk factors for dialyzer reactions, I wish I could stop this. Okay, is there a way to stop this from going ahead like this? Okay, let's just do this. Sorry guys, I'm gonna make you seasick by jumping all around the place. So a couple decades ago, when they were trying to determine what type of membranes were optimal for patients not to have reactions from, one of the types of membranes was called PAN, or polyacrylonitrile membranes. For some reason, when that membrane was combined with patients who were on ACE inhibitors, it had a very high likelihood of precipitating this reaction. Thankfully, this membrane is no longer on the market, so you won't see it anymore. Okay? So that was one of the reasons. Because it's anaphylactic or anaphylactoid, it's often related to production of IgE antibodies against an antigen. That antigen sometimes is the ethylene oxide or formaldehyde that's used to clean dialyzers. Okay? So when it's cleaning dialyzer and you've been exposed a couple times to this membrane, you produce antibodies and then you have an anaphylactic response to it. Okay? I say idiosyncratic, and I think this is actually the category that we see most often nowadays. So idiosyncratic simply means that, okay, we've got rid of this membrane, but we still see it. And for reasons that are not entirely clear, most of the reasons we see it now don't have a good explanation. So the patient might be allergic to the membrane, to something that was used to clean the membrane, but we really don't even know. And so the further they look, they have discovered some interesting things. There are patients, for example, that are allergic to heparin and are only ever exposed to it for the first time when they come on dialysis and have an anaphylactic response to heparin. And because it's given at the beginning of dialysis, it presents like a dialyzer reaction, even though it's not the dialyzer they're allergic to, it's the heparin. Okay? It does appear to happen more often in patients who have atopic conditions. So our patient, Mindy Fitzpatrick, at the beginning, she had exercise-induced asthma and she had eczema. Okay? These are conditions that actually increase your hypersensitivity and increase your IgE and your eosinophil levels, so you're more likely to have a reaction like this. Okay? It appears there's also patients who are on ACE inhibitors do have a statistically significantly increased likelihood of developing type A dialyzer reactions, although the absolute difference is very small. So because this is a very rare condition, if you increase it by 50%, you're going from like 1 in 1,000 to 1.5 in 1,000, so it's still pretty rare. Okay? Type B, really not serious at all. Remember, this is less serious, it happens later, most commonly has back and chest pain. The severity is quite mild. The initial theory with type B reactions was that it was related to biocompatibility of the membrane. So what that means is that if I expose you to something that is seen by the body as very, very foreign, okay, that you are more likely to activate complement. It's a pathway that you activate relative to foreign bodies. So for example, the very initial dialyzers are made out of cellulose. Cellulose the body recognizes as foreign. It says there is absolutely no business, my blood cells should not be exposed to this, there is no reason for this to be in my body, and therefore you activate complement. Well, the membranes are no longer produced with cellulose. Cellulose is not what the membranes are made out of. So over many, many generations of new membranes, they've gone from cellulose to modified cellulose to partially synthetic, mixed with cellulose, to fully synthetic. And so the synthetic membranes now are actually highly biocompatible. And that's why over time we've seen a significant reduction in the prevalence of type B reactions. Okay? So this is really what happens with type A reactions. And this picture would be the same if I was saying you had a peanut allergy, for example. Okay? So essentially what happens, if we look at the top left corner here, you have a B cell. B cells are what makes antibodies. Okay? That B cell is initially exposed to an allergen, okay, or an antigen, which promotes the production of antibodies. Those antibodies then sensitize that patient to subsequent exposure to that same antigen. Okay, so you have a mast cell here, the same receptor, the same allergen, but all of a sudden, because you've been previously exposed, you have all these antibodies, and it releases tons of histamines, lots of leukotrienes, lots of cytokines, and you get a very inflamed response. And that's why you get the tongue swelling and the dyspnea and the rash. Okay? That's in large part by these cells. So when I said the antibodies are formed, the antigen itself, like I said, it can be formaldehyde, it can be the ethylene oxide. Both of those can sometimes be used to clean the membrane, or it can be to the membrane itself, okay? Even without it being cleaned in advance. These patients often have increased eosinophils and IgE. Both of these are involved in the formation of an allergic response. And they often have atopic conditions like we talked about, the eczema, the asthma. Okay? It does appear that being on an ACE inhibitor does increase your risk, a small but significant one. Okay? Type B dialyzer reactions, again, these are the less serious ones. The pathway here is very different. Okay? The pathway here isn't allergy, it's complement. Okay? Now complement, that process is typically produced by bacteria, okay? So if I inject a bacterial isolate, you will activate complement, okay? And complement helps you to destroy the bacteria. Well, that pathway can also be activated because of exposure to foreign materials, okay? So that's one of the reasons why complement activation probably is one of the reasons why the outcomes of patients with Lyme's, foreign material, is not as good as with grafts or with fistulas, okay? Because you have a foreign body that you're constantly activating complement. What you see here is the alternative pathway, okay, that will be activated, and essentially you end up with membrane attack complex. That is the complex that helps destroy bacteria, destroy the foreign material, okay? That leads to cytokine release and a different type of inflammation that tends to be a little bit more mild. Symptoms you can see, very, very rare will you actually get hypotension. So if you see hypotension in a dialysis patient and you're thinking it's a dialyzer reaction, it's probably a type A reaction, okay? If it's serious and the person looks really, really ill, it's probably a type A reaction. If it's a little bit of mild dyspnea, mild chest pain, that goes away on its own, okay, with time, as our second case did, that's consistent with a type B reaction. So let's go back to the case, okay? So, this one really only works if you, it's hard to test you with, it's hard to test you without, by showing you the whole slide. Okay, so let's go back to Mindy Fitzpatrick. So she's 42. Remember, she had polycystic kidney disease, exercise-induced asthma. She dialyzes through a fistula. Her first dialysis treatment, 14 minutes in, she had some dyspnea, mild abdominal cramping. Dialysis treatment was stopped. Patient's blood was returned, supplemental oxygen provided. Run 2. 9 minutes in, dyspnea, swollen tongue, hypotension, itchy all over. Dialysis nurse stopped the dialysis treatment, returned the patient's blood, and provided supplemental oxygen. Okay, so what's the likely cause of her symptoms?
Dialyzer reaction.
What type?
A.
Okay, why is it A and not B?
Well, because she was showing more the severe symptoms of
Okay.
dyspnea and hypertension and.
Okay,
It's
good.
early on.
Early onset, good, good, good. And does she have risk factors
Yes.
in her history? What would her risk factors be?
Eczema.
Okay. And
Exercise-induced
asthma. Good, good, excellent. And what you'll see here, there's a couple other things that were on that list that are not impossible but are less likely. So air embolus is more common in patients who have lines, okay? So that's one strike against it. And it often happens at the very start of dialysis or after there's been some technique or something done with the line during dialysis, either reversing the line or something like that, okay? And so this is not the case in her. So it doesn't really look like that's likely. Myocardial infarction could be, but I mean really she's got absolutely no risk factors. She didn't have chest pain the first time, so it's, and you know, myocardial infarction isn't usually associated with the, you know, swollen tongue, the swelling, the rash. You know, those would be a little bit atypical. The dialysis-induced hypoxemia. Okay, well, I would have needed to tell you she was hypoxemic, and I never told you that, right? The timing actually fits. So dialysis-induced hypoxemia typically happens within about 30 minutes. It peaks at 30 minutes, and then it sort of goes away on its own as dialysis continues. So it's not impossible, but certainly nothing highly suggestive. Dialysis-induced hypotension. So usually that happens towards the end of dialysis. So when we talk about dialysis-induced hypotension, that usually involves towards the end when we've pulled off a lot of, we've performed a lot of ultrafiltration and removed a lot of fluid. At the beginning of dialysis, that isn't commonly when we see it. Okay, we usually see it more towards the end. The same thing for dialysis disequilibrium. So that usually, even though, so does anyone know what dialysis disequilibrium is? Someone explain that to me.
It's when the urea is not being cleared in some of the smaller vessels, you get swelling. Usually get a bad headache.
Yeah, so usually it's when you very rapidly shift the osmolality of patients in a patient's brain. Okay, so that involves very rapid correction of uremia or very rapid correction of uremic toxins. And so that's why oftentimes you'll see us at the beginning when we do dialysis treatment, the first, second, and third, we'll do for a shorter period of time with lower blood flow rates because we want to very slowly bring them down and to prevent dialysis disequilibrium. That commonly presents with a whole host of, a spectrum of neurological symptoms from anything from headache to coma to death on the opposite side. But that's more common either towards the end of treatment or even after treatment, okay, that a patient will start complaining about those symptoms. And dialyzer reaction. I think this one was, this case I pulled out because it was a type A reaction that she had, okay? Let's go back to part 2. So part 2, okay, Sunil, so we're going to quickly review again. He's our Sri Lankan gentleman who had chest and back pain that developed 30 minutes into treatment, and it went away after talking with Dr. Willie Hinde. Okay, 65 minutes in, his chest pain is much improved. So, what do we think this is? I see a lot of people saying type B reaction. And that's what it is. It's a type B reaction. So, again, air embolus for the same reasons. It's more common in lines, often at the start, post-line intervention, which isn't here. MI is not impossible. So he has all the risk factors in the book. Okay, chest and back pain on dialysis, absolutely. That could be an MI, absolutely. So, I mean, I think I probably would send off the ECG and biomarkers in this patient, even though, you know, you might later find it to be a type B reaction. Nothing wrong if you send that off. Pancreatitis doesn't go away like this does, okay? You wouldn't expect that. Uremic pericarditis, well, I mean, what's the likelihood he has uremic pericarditis? This is his 4th treatment here, and he was getting treatments in Sri Lanka before he arrived. Pretty unlikely he's all of a sudden uremic, right? Seems like he's been stable on dialysis a lot, so pretty unlikely. Dialysis disequilibrium, again, that usually happens towards the end or after dialysis. Dialyzer reaction, probably a type B here, and dialysis-induced hypoxemia is unlikely, okay? So, last slide. So, the mechanism here for type A, it's like anaphylaxis. It's not always anaphylaxis. There are sometimes people who exposure to ethylene oxide or formaldehyde will actually precipitate histamine, and so it looks like anaphylaxis, but it isn't a full-blown anaphylactic response. It should still be treated like it is an anaphylactic response, though. And so treatment there, if you thought it was a type A reaction, would be epinephrine, steroids, antihistamines, and you may need to give them bronchodilators as well. Type B, there isn't really treatment. You support them. It gets better on its own. You continue dialysis, and if they are on a type of membrane that's not biocompatible, you might switch them to a more biocompatible membrane. So we usually, in both of these patients, would change the membrane. So if they're on an FX800, you switch them to an Exceltra, done, right? And you monitor them closely on the next time they're treated as well. Like I showed here, there is one thing that we do habitually that we should think about. So you'll notice in case 1 and case 2, whenever dialysis was stopped, we returned the blood to the patient. And this is what we always do. Just intuitively, this is what we always do. But in these cases, you shouldn't. In these cases, you should not return the blood to the patient. And the reason is that blood is essentially blood exposed to allergen, which is going to precipitate an inflammatory response in the patient. So by giving it back to the patient, you have the potential to make their allergic reaction worse. So in those patients, you throw away the blood, okay? And that will actually make their allergic reaction less, okay? I've shown you the biocompatibility here of the membranes. Bottom line is, we don't use cellulose anymore. We don't use substituted cellulose anymore. You'll rarely find cellulose synthetic, like a mixture of cellulose and synthetic membrane. Basically, all of our membranes are synthetic membranes, okay? And those are designed in a way, and the materials chosen to be biocompatible, okay? To cut down on this issue, in part this issue, okay? That's it. That's all we got. I'm 1 minute under time.
What's the difference then when we're switching dialyzers? So we've got a synthetic membrane that they're allergic to. What's so different about the Exceltra then?
So they're both synthetic. The difference is that if we don't know what they're allergic to, say they're allergic to the membrane, their allergy and the antibodies they produced against that membrane are specific to an antigen on that membrane. So they won't react to another membrane if it's a different material, right? It's kind of like you're allergic to peanuts, but you're not allergic to kiwis, right? So rather than eating peanuts, we're going to have you eat kiwi from now on, right? It's basically the same thing. All you're doing is you're changing the allergen that they're exposed to, and they don't have antibodies to that one, so you should be fine. Now that said, it really depends what component you're allergic to. If you're allergic to formaldehyde, and formaldehyde is being used with both of those membranes, then you do theoretically have a possibility of dialyzer reactions to both. But thankfully nowadays, most of the time you see a dialyzer reaction, it's to the membrane itself, not to the cleaning mechanism, in part because we've cut down on reuse of dialyzers. So that's one of the ways that we can cut down on this.
Yay!
All right, we're done? All right.
You can fill out an evaluation form, just set them down there and the other end.
Done.
Yeah, it's about it. For you. All right. Sorry. I know, right? So Ben, you know